Hi guys, welcome to another episode of Radiology 365, still talking about pulmonary infections, and today we're going to be delving into the topic of tuberculosis. So pulmonary tuberculosis is caused by the organism Mycobacterium tuberculosis. Now, initial exposure to tuberculosis can lead to two clinical outcomes. First, you may have a contained disease that's usually in about 90% of cases, and this results in calcified granulomas and/or calcified hilar lymph nodes. Usually, in a patient with normal immunity, the tuberculous bacilli are sequestered with a caseating granulomatous response, so they are walled off, and that eventually leads to what we are talking about, the contained disease. It doesn't go on to cause any illness. Then you could have primary tuberculosis as a result, and this occurs when the host cannot contain the organism. Primary tuberculosis is seen more commonly in children and immunocompromised patients. Then there is reactivation, or what we call post-primary tuberculosis, and this is reactivation of a previously latent infection. So primary TB represents infection from the first exposure to tuberculosis. Primary TB may involve the pulmonary parenchyma, the airways, and the pleura. Primary TB often causes adenopathy, that's disease within the lymph nodes. They could get enlarged. As many as 15% of patients who are infected with primary TB have no radiographic changes. So you may look at a chest x-ray and it may look normal in someone who actually does have primary TB. And the imaging appearance of primary TB is usually non-specific. You can't look at an image of someone who has pulmonary TB and stick out your neck based on only the imaging findings and say this patient has primary pulmonary tuberculosis. The typical imaging manifestations of primary TB include lobar consolidation. You may or may not have pleural effusions. You may or may not have lymphadenopathy, although lymphadenopathy is almost always present. Although not all of these things that I've mentioned need to be present. Primary TB may also occur in any lobe at all. The other thing too is that primary TB can also present with isolated pleural disease. It can also have miliary disease, but these two presentations can also be present in post-primary TB. There are some other classic imaging findings of primary tuberculosis that are not always seen, like gun focus, which is an initial focus of parenchymal infection. It's usually located in the upper part of the lower lobe. So you would see a solid looking mass-like lesion in the upper lobe called the gun focus. And then you may also have what we call a Ranke complex. That's the gun focus plus hilar lymphadenopathy. Sometimes cavitation may occur, but usually not the case in primary TB. So if you do see cavitation, you should not be thinking of primary tuberculosis. So this chest radiograph on the left here shows a vague right upper lung opacity where the arrow is. It's around here. It's a vague lesion. And the CT shows a patchy opacity in the lower portion of the right upper lobe with adjacent stream bad nodularity. So if you look around, there are some nodules that appear to have a stream bad appearance. This patient's sputum grew Mycobacterium tuberculosis. Then on the far right image, it's a case of tuberculous adenopathy. It's a contrast enhanced CT scan of the neck and it shows marked right-sided adenopathy. These are lymph nodes that have peripheral enhancement and central necrosis. This hypoattenuation in the center with the peripheral enhancement. Now, talking about reactivation or post-primary tuberculosis, reactivation TB usually occurs in adolescents and adults and is caused by reactivation of a dormant infection acquired earlier in life. Clinical manifestations of reactivation TB include chronic cough, low-grade fever, hemoptysis, and night sweats. Now, just like in primary TB, reactivation TB most commonly occurs in the apical and posterior segments of the upper lobe and then the superior segment of the lower lobe. In an immunocompetent patient, the imaging hallmarks of reactivation TB are upper lobe predominant consolidation with cavitation. That's the key point there. Then you may also have stream bad nodules and they would suggest some endobronchial spread of the disease. Low attenuation adenopathy is also a common additional finding. It's also more commonly seen in immunocompromised patients. Then there is such a thing as a tuberculoma, which is a well-defined rounded opacity consisting of an encapsulating fibrous wall with central caseation. It's usually also seen in the upper lobes. All these are features of post-primary tuberculosis or reactivation tuberculosis. So this frontal chest radiograph shows a cavitatory lesion in the left upper lobe here, and is confirmed by CT showing this cavitating lesion here. The differential diagnosis of this appearance could be a cavitatory primary lung cancer, but that would have a much thicker and more irregular wall. This was also sputum confirmed to be tuberculosis. Then there's the entity we call healed tuberculosis. After the tuberculosis has been treated and it heals, it usually heals with scarring. And so the radiograph would show features consistent with scarring. So reticular opacities, loss of lung volume, elevation of the hilar, crowding of the ribs, and vasculature in the area. You may also see similar findings on CT. You may also see some calcified granulomas signifying healed disease. So this radiograph shows scarring with volume loss evidenced by the reticular opacities in the left apical region, with some evidence of volume loss shown by crowded ribs in this area. The CT shows scarring as well, evidenced by these multiple reticular opacities. Then TB can also have a miliary pattern, and that is a diffuse random distribution of tiny nodules seen in hematogenously disseminated TB. Miliary TB can also occur in primary TB, but it can also be seen in reactivation tuberculosis. So in these images of miliary tuberculosis, the radiograph and the CT show innumerable tiny nodules in random pattern reflecting hematogenous seeding of TB. So to summarize, primary TB usually has non-specific findings. It may be normal, it may have features that just look like a pneumonia, but you can't look at a plain radiograph or CT and say this is primary TB. You can just give it as a differential. But for post-primary TB, you would usually have cavitatory lesions, and for healed TB, you would have scarring and loss of lung volume. Miliary TB would show multiple miliary nodules. So I hope that puts things in perspective. Next time we'll talk about atypical mycobacteria, endemic fungi, and viral pneumonia. I hope this was helpful, and as usual, if you did find it helpful, share with someone who you think would need it, and I will see you in the next one. Oh yeah, like and subscribe.